Corneal abrasions are going to be one of those things that you see with relative frequency, either in the ED or in an outpatient setting. Unfortunately, corneal abrasions are underreported, and so we don't really have a great idea of how common they are, but we do know they're common. And so if they're underreported, not only are they common, but they're very common. So this falls under disorders of the cornea. Keratitis involves some inflammations of the cornea, which are infectious in origin. There's also photokeratitis, which is a kind of similar process, but it involves involves ultraviolet exposure. Corneal abrasion is going to be what we talk about here, and then there's also some other less common disorders of the cornea involving dystrophies, which are primarily genetic, and keratotorus and keratoconus. So the cornea is here in relation to the rest of the eye, and it is consistent with the sclera. The cornea is clear, it's transparent, and that's important because we need to allow light to get through the anterior part of the eye, through the lens, and ultimately to the retina, where the image is processed and sent on through the optic nerve. So the cornea, being clear, is made up primarily of collagen. It doesn't have any arteries or veins. It gets its nutrients through the aqueous. And the anterior aqueous is directly posterior to the cornea. The cornea also has some refractive properties. I think it's about 46 diopters. Don't quote me on the exact number, but it's somewhere around there. And that's important for ultimately projecting the image onto the retina. And there's some disorders where the cornea is not shaped properly, and that can result in distorted images. And as a matter of fact, LASIK surgery primarily alters the shape of the cornea to improve the focus of the image. So that's the surgery that you get to correct abnormally shaped lenses. You're not necessarily changing the shape of the lens, you're changing the shape of the cornea to compensate. Okay, so this is a cross-section of the cornea. Don't worry about the histology, but it's just good to know that there's different layers of the cornea, so we kind of have an idea of where these things are happening. So this is the outer side, outside of the eye. This is the inner side. This would be the anterior aqueous chamber here on the left. So starting from the outside, working our way in, we have the epithelium. This is stratified squamous epithelium. So these outer cells are flat like pancakes. You can see the flattened nuclei here, and then they become a little bit more columnar as you work your way inwards. Separating the epithelium from the stroma is a thin layer of basement membrane called Bowman's layer. Then you have the stroma here, which is the largest layer that's in the middle. And then there's a sort of basement membrane for the endothelium that's called the Descemet's membrane. And then the endothelium is the innermost portion, and that's a squamous epithelium. Okay, so a corneal abrasion is a mechanical or chemical disruption of the corneal epithelium. So we're talking on the outside of the eye here. And this is the most common eye injury among children, and probably the most common eye injury in the general population as well, because you can get them so easily. Lesions heal very quickly. The epithelium has a very high turnover rate. It replaces itself generally within 24 hours, but the time to healing generally depends on how deeply the cornea was injured. So if it was just a couple layers, it'll heal faster than if it were several layers. Typical causes, you can imagine direct injury, so fingernails. If you're itching your eyes, mascara brushes. I don't have personal experience with that, obviously, but that's where you take that applicator and rub your eyelashes to thicken them up. So it's very imaginable that you can accidentally touch your eye that way. Branches, so if you're mowing the lawn and you run into a branch and it pokes you in the eye, that can cause an abrasion. Chemical injuries like mace, this is very common. The mace can harm the epithelium, and that will cause a larger abrasion. Blowing dust or debris, extended use of contact lenses, really just contact lenses in general, because if you're placing a contact lens onto your eye, you're actually getting your finger onto your eye and you might get your nail onto your eye. I used to wear contact lenses until I got LASIK surgery about 2 years ago, and believe me, I have extensive experience with having had corneal abrasions. Not comfortable. And then there's also iatrogenic causes. A lot of patients who are disabled on bed rest, who need help from nurses to keep themselves clean. The nurses may be washing their eyes and accidentally cause a corneal abrasion. The symptoms, typically the patient will present with eye irritation or even pain, but typically this is a sensation of having a foreign body in the eye, sort of a gritty, itchy feeling, but you can't get the thing out of your eye. You can have photosensitivity. Blurred vision is certainly possible, especially since if you have an injury, it will change the refractory property of the cornea in that particular spot. The patient generally will be able to relate to you some kind of a trauma to the eye that preceded the pain, but you're usually going to have to milk that out of them. They won't just tell you because they might not know that rubbing their eye caused this, or putting their mascara on, they might have hit their eye. So you should definitely ask, have you rubbed your eyes? Have you used any mascara? Has anything gotten into your eyes? When did this come on? Were you doing anything at that point in time? And of course it should be relatively recent, because corneal abrasions tend to heal on their own within about 24 to 48 hours. So the physical exam will typically require a topical anesthetic. Patients with corneal abrasions, especially if they're severe, especially if it's a child, they won't want you to touch their eye. So a topical anesthetic is useful, and that anesthetic will actually really make a difference for the patient. And that's one of the ways you can tell that it's probably a corneal abrasion. You're just putting an anesthetic on the very outer portion of the eye, and it's only going to hit outer nerves. And if that really makes a difference, that'll help you sort of narrow your diagnosis down, or at least point you in the body of a corneal abrasion. You may note some conjunctival erythema, and a lot of that is not due to the abrasion itself, but due to the fact that the patient has been rubbing or trying to wash the quote-unquote foreign body out. There should never be pain on eye movement. That's a sign of something else. If there's pain on eye movement, then there's something wrong with the extraocular muscles or with the optic nerve, and so that should never be present. Also, there should never ever be corneal haze. That's going to point you more towards a keratitis. This is just on the outside, so there shouldn't be anything inside the cornea. And the pupil should be normal, although sometimes there can be a reactive miosis, but in general it has normal reactivity. You should also inspect the cornea and lids for a foreign body. A lot of times foreign bodies will be darker. They may sit around the iris, so definitely inspect the cornea, because there might indeed be a foreign body that's present rather than an abrasion. In your differential, you're going to have, of course, other causes of red eye. There's not always significant red eye with corneal abrasion, but if there is, you need to narrow down, rule out the other causes of red eye. So conjunctivitis, typically with conjunctivitis, you're going to have a discharge. And also with conjunctivitis, you should not have abnormal vision. You shouldn't have any blurry vision. Acute anterior uveitis typically has a poorly reactive miotic pupil. And acute angle closure glaucoma will not be a foreign body sensation or mild pain. This will be the worst pain the patient has ever had in their life, and they will have extremely blurry vision. Infectious keratitis is another possible cause, but in this case, typically the patient will have a corneal haze. You can, if you're worried about infectious keratitis, if there really is significant red eye, you can do a fluorescein test to look for an ulcer. But with infectious keratitis, there will be ulceration. Ultimately, we will do a fluorescein test to test for corneal abrasion. That's next. But we'll talk about how we differentiate that out. Photokeratitis, another possible cause of this itchiness, this uncomfortable eye. But typically with photokeratitis, there has been an exposure such as skiing or snowboarding, something outside where you weren't using lenses to protect your eyes from the sun. And then a foreign body, of course, is also on our differential, and that's why we're inspecting the cornea and lids for foreign body. So here's a corneal abrasion. Apart from maybe a little bit of erythema, we don't see anything wrong with this eye, and that is what you would see in a corneal abrasion. It doesn't look like there's anything wrong. However, when we use fluorescein, we see that there is a problem here. So normally when you use fluorescein, what you're doing is you're putting this dye onto the patient's eye, onto their cornea, and fluorescein will not attach to the epithelium. However, if the epithelium is denuded, then Bauman's layer is exposed and the fluorescein will attach to that. And so this is all areas here where there was denuded epithelium. And so this is very linear, so this can possibly be from a mascara applicator. It's another corneal abrasion. And these are a little bit bigger, but this is also a corneal abrasion according to the source where I got this from. This also looks very similar to an ulcer, and your differential is primarily, in that case, going to be how long has this been going on, was there any preceding trauma. So for diagnosis, we're going to use fluorescein staining, which will demonstrate the abrasion either grossly or under a cobalt blue lamp or a Woods lamp. Sometimes you don't even need the lamp. This is the I'm not sure if this is the same eye or not, but it looks like the same eye. But here you can see the lesion is present without a lamp, but some of the smaller ones you may need the lamp to sort of amplify the fluorescein. Under the suspicion of ocular trauma or a retained foreign body, you should consider an ocular CT or an MRI if the object is non-metallic. Obviously, you don't want to get a magnetic resonant imaging of anything if you suspect that there's something metallic in there. But this is why you look for a foreign body. If the foreign body looks very superficial, you can try to wash it out with some saline. If that's not successful, you can apply some anesthetic and try to get it out with a cotton tip applicator. Anything deeper than that, you need to send off to an ophthalmologist. For treatment, this is something that does not last very long. Corneal abrasion does not last longer than 48 hours in most cases. So primarily what we're concerned about is pain control. So typically we'll just give the patient PO pain meds. Oxycodone and acetaminophen is usually good enough. Some sources I've seen have actually said that you can use topical pain medication, but again, you run into the problem there of reducing or inhibiting the healing process. So I'm not so sure how good of an idea that is. Reassure the patient that this is not something that's going to last very long, should be gone within the next day, and they'll usually be okay with PO pain meds. Prophylactic topical antibiotics are controversial to use routinely, but there are certain patients in which you would want to use prophylactic antibiotics, especially patients who wear contact lenses. And the reason why is because they're at greater risk for keratitis. So especially if the patient is a contact lens wearer, if they have a recent history of swimming where they can be exposed to acanthamoeba, you'll definitely want to give these patients topical antibiotics. But it's really at your discretion. The antibiotics that are typically used, we want to cover Pseudomonas. So one of the newer generation fluoroquinolones can be used like ofloxacin or gentamicin, but make sure it covers Pseudomonas. And then patient education, of course, avoid contact use until it's healed because we don't want to expose the patient to any any bacteria or fungus or Pseudomonas or acanthamoeba that's on the contact lens, and then use protective eyewear, especially if they got this occupationally. The patient, if the pain does not go away within 48 to 72 hours, or if it gets significantly worse, they should return, and typically they'll be referred to ophthalmology.